Malaysian Association for Bronchology and Interventional Pulmonology, Malaysian Thoracic Society, European Respiratory Society, and the Malaysian Medical Association. Dr. Vijay.
Okay. Hello, good evening. Is it? Okay. So this one is not okay.
This is to record.
Oh, okay. Hello, good afternoon. Thanks for waiting for after the lunch. All right, I know it's very difficult to give talk after lunch. That's why I asked them to give extra 15 minutes break so you can refresh. Okay, we shall move on to our topic today. The topic was given to me hugely burdened because why? Lung cancer screening is a topic for exam, those who are exit viva for respiratory, and early detections under the syllabus, ALK mutations under the syllabus. So it's a 3 syllabus. If you're going for the, we call it a respiratory exam, you need to study this before you go for exams. So I tried to compress everything into a simple version so that we will not, okay, yeah. So I have no conflict of interest to declare. So the table of content, we talked a little bit about epidemiology. We discussed about all the study in the lung cancer in overseas and Malaysia, and what's the lung cancer screening process in Malaysia, rate of screening. We talk about ALK mutations as well as treatment options. Okay. Let's talk about the epidemiology. That, as we know, lung cancer, second most commonest cancer in Malaysia, is increasing trends. You can see Chinese male is outnumbers everyone. They have a high probability to have a lung cancer compared to Indian male. This is our data from the registry in 2021. Okay, so don't worry, only in lung cancer, Indian outrates Chinese in diabetics. All right. So why? What the risk factor? I think everybody knows. This is because of smoking, some exposures because of the radons as well as the environment pollutions. And so smoking still high number of incidents where patients have lung cancers. And what are the symptoms? I think you guys well knows from this. They can have heterogeneous symptoms. What you read in the Google doctor might be not same. What we see in the clinical practice, we do have a patient come with a CNS manifestation, stroke-like symptom. You do a CT brain, there's a huge tumor. Then you do X-ray, there's a huge lung nodule. So they can come just with the stroke-like symptoms. They also can come just with the loss of weight and loss of appetite. So we don't know. Probably we will classify this old disease. Once you pension, you have old disease. Loss of weight, loss of appetite. So you think because of the I'm aging, but it is not. If you're losing weight more than 10% from the initial weight, you need to be very cautious and really need to look for medical practitioner to explore what's the causes, whether you have a gastritis, whether you have an infectious disease, or you have some malignancy brewing without your giving any warning symptoms. So this is our latest registry in 2021 given up by the IKN. You can see number of the lung tracheal bronchus cancer is increasing in the trends, okay, and that's most commonest death because of the pneumonia as well in the Malaysia, okay. Number third, of course, once you become pensioner, always said you get a many diseases, arthritis is most commonest, and then secondly, you have to look for malignancy. Your age after 65, the propensity for you to get malignancy is higher. Not only for lung cancer, any other diseases as well. So as we know, sadly, in Malaysia, even in the European world, most of the lung cancers comes in more than 95% is the later stage. Stage 3B and stage 4, sorry. So more than 90% who are presented to us is late cancer. As I mentioned earlier, once you become pension, you become more complacent, relaxed, taking care of your grandchildren, your granddaughter, going for vacation, going for a tea with your friends, then you're losing weight, you're coughing, oh, it's okay, I have normal cough. You see one GP, you don't like, you see other GP. Other GP give you a good picture, this is good, I recommend to the another 5 friends. And the cough come back every 2 months. So that's how the life goes on, and that's how you end up being in a third stage. What we see in the common clinical practice. And the irony is, the later you comes in, the poorer the prognosis. So you can see those who comes with the later stage of the lung cancer, especially stage 3 and stage 4, the prognosis are very poor. So we did a small data in University of Malaya, my boss Professor Liam, who retired now. We can see the incidence as well as the stage the patient comes into our clinic. You can see stage 4. Yeah, stage 4 and stage 3B are very commonest, and very less people coming in the early stage. So this is our center data. Of course, it's already, but we are in the verge of reviewing this data. Sorry. Yeah. Okay. So as I mentioned earlier, anything late is always the worst, isn't it? Okay, even a cardiovascular, even breast cancer, even prostate cancer is not something isolated for a lung cancer. So if you diagnose late lung cancer, of course your prognosis are very poor. So that's why we embark the reason and the importance of the lung screening. We know this equivocal towards your early lung screening is for early curative and early good outcome. So what evidence shows, early lung cancer detection is definitely improve your treatment outcome, definitely improve your quality of the life. Right? So this is a much accepted notions from all over the world, especially in the lung cancer as well. So if you talk about when the lung cancer exists, it already exists in 1970s. Right? It's already ever in 1970s. And this trial actually is a landmark trial. We call National Cancer Lung Screening Trial and also the Nelson trial. So this is actually given a lot of impact and shows the world that what is so significant, the importance of the lung screening for those patients. Okay. So what we done in Malaysia? Sorry. So of course, in Malaysia, right, we also must do some study. Unfortunately, the Malaysian study involved 14 sites failed because it was in 2017. Sadly, it need to be terminated earlier because of the lower awareness, refusal to be screened, and fear of diagnosis of lung cancer. So all people say, never mind, I die lah. Okay, if we talk about other people, kita redo sajalah. Alright, so that is the ones actually caused this trial was failed in Malaysia. Okay. So what we done, of course, promotion is always better, advertisement is better. So as a Malaysian, you must give things free in order to attract. Anything comes out of pocket is always big problem, you know. So we are in a university hospital. Some of the medications we have access all the new medication. They always caution us, why you don't have free. I'm not the person supposed to answer the questions, but even yet the answer they will ask you, why you people never fight. My God, how to answer this question? Maybe somebody can give me a better answer, how to answer for this kind of questions, you know. So I know the expected from our perspective in all the Malaysian hospital services, we provide as free as we can, but we see our neighboring country, any part of the world, no longer medication or medicine will be provided free. Okay, so this actually managed to attract quite a number of patients comes in for the pre-program for the lung screening. It was done together with the Lung Cancer Network of Malaysia. It's basically established to create awareness of lung screening. It was established in 2018. Okay, it was actually composed of the thoracic surgeon, respiratory physician, physiotherapists, as well as psychologists. Okay, so since I'm in NCS, I need to promote few of these guys. This guy is the most important guy, if you guys know him. Alright, and this is our current minister. Alright, so of course Dr. Murali, as a person in the National Cancer Society, as a CEO, is strongly and very vocal in media to advocate the importance of the lung screening in Malaysia. And now recently we all embarked in something called Lung Initiative Program Landscape in Malaysia. We just had a first draft and second draft. Our beloved Health Minister, Dato Sri Ahmad Zulkifli, is very much into and support us this lung initiative, which look into in every angle from the primary care up to the tertiary level. Okay, And of course, the question comes in your mind is, what is the appropriate method for lung screening? Okay, and it should be very highly sensitive, affordable, and repeatable, cheaper, and less risk. Everything must come in the silver spoon, isn't it? Okay, all right. So what have we done so far? Blood test. Unfortunately, lung is the only organ. We don't have any of the tests available in the market to test for lung cancer. Of course, sputum shows in many studies that is a very low specificity and sensitivity, and chest X-ray is not very good if your lesions are smaller, less than 1 centimeter. So what is the most suitable? Of course, low dose CT scan. Okay, I think the numbers and the name is already implying that your exposure to the radiation is much lower compared to your conventional or standard CT scan you do if you have a diseases. Okay, so I know you guys, so much people comes in, they will talk about so much of radiations, you know. So this is standard radiation, we call 1.5 milli SV, and this is your low dose CT. So when we ask people to go for low dose CT, I'm so much exposed to the radiations. Okay, so this is the questions comes to you. So how do I answer this question is, I will say, since Malaysia, because of Tony Fernandez, everyone can fly. Alright? But we forgot that even by flying, you already have exposed to radiations. And the radiation is higher, depend on altitude. If altitude more than 8,000 feet, the radiation is higher. The number of hours of the flight is even higher. Whether you're going for North Pole or South Pole also make difference of the exposure to the radiations. So unconsciously you're not realizing that every year, I think all of you must fly twice a year, isn't it? So we accumulated more than 10 years. Maybe NCSM workers don't fly because the salary is low. I think normal people will fly often, as maybe twice in a year. Maybe go to Thailand or go to Vietnam, go to any countries, alright? So these radiations actually do affect your health if you compare doing health screening. So this is, sorry. Okay, so if you compare this, of course much lower. We can say nearly 4 times lower than your conventional, and you do expose radiation when you're flying. So when we put the question to the patient, really? I say yes, really. It's not it is not a myth created by us. That's why if any of your siblings, your daughter working in the airline, so whenever they fly more than 8 hours, they need to rest 2 days. We're wondering, right, why are these guys doing 3 days, 2 days? Go to California, 3 days must rest and come back because of this. So they need to deactivate the radiation effect. Alright? So that is the aviation rule. Okay. Smoking, yes, it do cause radiation. So you ask the smoker, right? So smokers, they with realizing or not realizing, do cause radiations. So the 2 components actually involved, that's called polonium and lead. Even they wash the tobacco leaf is still exposed. So how much they expose? They can actually, this amount of the radiation they exposed per year if they smoke 1 pack. So even smoking have a radiations. So I think doing a low dose CT scan, it is not an issue. If you look at all this aspect, it shouldn't be a cautions for your own benefit if you're doing a CT scan. Okay? So as I mentioned earlier, so low dose CT scan is much better because it can identify a smaller nodule. Number 2, of course, low radiation. I think I managed to convince you all with all the facts. Number 3, of course, available all the government and public hospital. Sorry to say, public hospital, we have overload even for the treating patients. So currently easily accessible in the private hospital. And of course, many studies have a much evidence using the low dose CT scan compared to other modality for now. Of course, richer country like US done screening with PET-CT, but I don't think so we will have that liberty to using PET-CT for lung screening. So who are the populations? So we must have a target population. So number 1 is those, this is a new recommendation from the American Society. So they actually bring down the age from 55 to 50, and number of pack is 20 packs a year. So how do we calculate number of packs a year? If you smoke 1 pack per day for 1 year, for 20 years, equivalent to 20 packs a year. Alright? And if you quit any point of time, does not means that you don't have a risk of getting a lung cancer. Alright? And of course, you should not have any active lung cancer. You should live more than 3 years. Of course, you don't do lung cancer, those people are in bedridden, going to pass away in 1-2 years. Does defeat the purpose, isn't it? Okay? So this is a very landmark study, as I mentioned to you. This is an old study. We can see this study already shows lung cancer actually reduced 20% of the mortality from the screening compared to the X-ray. So it means 2 people you can actually survive by doing lung cancer. Alright, out of 10, 2 people can survive. Alright, so of course overall risk factor, I think I don't want to repeat the same things. Of course tobacco smoking is higher and risk. Alright, so how about vaping? Alright, so we actually I'm in the verge of actually presenting this first case, most probably in Malaysia. So for now I need to be diplomatically and politically correct. That's why I put here making the causation case between e-cigarette and the lung cancer. So if I said e-cigarette causing a lung cancer, everybody will turn bullet towards me, because many people are still in favor of vaping. Okay, so we are going to present this case in our Malaysian Thoracic Society Congress in end of this month at Johor. So hope he makes some impact. Alright, so this is next topic about the lung cancer and mutation. So we will take maybe 30 or 1 minute break, but I'll take a questions about the lung cancer. Yeah.
How about MRI scan or PET scan?
Yeah, as I mentioned earlier, MRI and a PET scan, number 1 is expensive. Okay, number 2, of course, even the richer country not adopted this, because in Malaysian setting it's going to be difficult because we have very high prevalence of TB. So you might have an old TB scarring and all those things. So for the answer now, no strong evidence with the MRI and PET CT.
It's not accurate or
No strong evidence means you can do, but of course no much evidence. And not required for the lung screening at all. Yeah. Any question for the lung screening in Malaysia? Oh, you put me headshot. I know COVID is a very sensitive. So far, no data been shows. Even in the China trial, or also in the US, in Italian, they never showed any correlations COVID associated with the lung cancer. So the study are very false study. So we can't. If follow the evidence, no.
But a lot of videos on it.
Sorry.
A lot of videos on it. A lot of videos on it. On the correlation between COVID and cancers.
Yeah. But so that's not established statistically significant. But what we established now is actually post-COVID, the asthma flare-up that we already established. Means you have asthma in childhood. After COVID, the asthma become bad or is flare-up. That's we already established for now. Yeah. Okay. So let's. Any questions? I think we can finish very fast. Okay. So lung cancer mutation, ALK mutation. Bear with me. This is a little bit of very much or evidence based. Okay. And they give me 2 days topic. One is for public. Tomorrow is for the healthcare professions. So I didn't prepare for you all, but this is can use for you all as well. Okay. So this is the very much classification of the lung cancer. Lung cancer evolved in the lung cancer classification in the period of time. You can see it's become more and more. Last time only 2. Okay, becomes squamous and non-squamous. Now we have a many spectrum with all the oncogenic drivers. Alright. And of course, if you compare US and Japan, because Japan have a very extensive study on the lung cancer, because their program is very good and people are willing to come to do the screening. And you can see the most commonest in the US, in overseas, is the EGFR mutations. But in Malaysia or Japan is much lesser, alright? And KRAS is second is highest, but in Malaysia or in the Japan, the KRAS mutation is lesser, alright? So don't worry about this, okay? I just want to show you all only, so that I look better, okay? So what is our great achievement in terms of the lung cancer? This is what I always tell to all my patients who come to see us. Don't give up, don't think chemotherapy is the only options. Because of the evolutions of the molecular testing, we have a lot of targeted therapy. So what is a targeted therapy? It means these are the therapy you can consume tablet. You don't need to come to hospital. And of course, if you consume via the tablet, the side effect lesser, coming to see us is lesser, coming to hospital is lesser, and of course, the efficacy is a lot better. Okay? So I think they already advocate you about ALK. We just zoom into the ALK. So these are treatment, all this treatment available in University Malaya only. Alright? So all this, fusotinib available in KKM, serotinib, yeah, they have, but all those things we don't have because expensive. Okay? So I give you the price list. So the most superior one is called olatinib. Alright? In a year, it costs you, after the price revised, 1 year, it costs you approximately 120k.
150.
Okay, this is the initial price. And now, it's become 80,000 plus after we discuss with them, after we start a number of the patients and everything. Of course, they have some patient assisted program. And this is the old drug, fusotinib. It's 1 month is 2,800 ringgit. Depend on the dose as well. So that's why lung screening is a lot better, rather than you are subscribing all these Porsche, Mercedes-Benz, and BMWs. Alright? Okay. We have a number of patients. Okay. Their effort to take this medication we gave to them. Alright, so what is the treatment available up to now? We will focus on the ALK. Yeah, so we have all those things. Alright, and of course you cannot afford this, you will go back to chemotherapy, is much cheaper and as well. Alright, and the third, the most important I mentioned is the molecular testing. Prof. Padma or Raja Dure is one of the very senior pathologist who now is in SGMC. I worked with him more than 10 years. He's one of the most outstanding pathologists in Malaysia. Alright, so we come out this key biomarker that needed any of the lung cancer patient who diagnosed in Malaysia. So most important is EGFR, ALK and ROS. So it's become a standard care, and this was the meeting or discussion. During this discussion was take place approximately around 2017, and they published in 2019. Okay. And what are the tests we do available in Malaysia? Of course, immunochemistry is all method, FISH method, real-time PCR, and this is what's commonly used. We use next generation sequencing. Okay. So what is the most difficult is because it's work only one technology with one flow and significantly lower sample required. So my photo is intervention pulmonologist. We do a lot of biopsy with all the different gadgets. So whenever we send the sample, the pathology always say not enough sample, not enough sample, not enough sample. Because sometimes to get a biopsy is not easy, it's very difficult because of the nature of the tumor, because many of the tumor already have a necrosis. Also necrosis, the tissue already died. Maybe only certain part is still active. Alright, so that is the reason. And of course now we have readily available this NGS Express 50 gene. You don't need a 500 gene. Of course, unless you have insurance 1 million, 2 million, you can ask for this. But many of the genes even detected, no treatment available. So that's why in Malaysia we limited ourselves with 50 gene, and this will cost you around 3,000 ringgit. Okay, and in University Malaya we're doing a study. We subsidize this test for 1,000 ringgit. If the study finish, of course you have to go back 3,000. And what is the ALK? ALK, of course, this is present in the chromosome in a genetic. It expressed one of the fusion called EML4. All the method can use to detect the ALK, all right, and mostly is adenocarcinoma. And this is the treatment progression available even in Malaysia. We have all the generation, first generation, second generation, and third generations. So whether you want which generation depend on your bank balance, depend on your insurance. All right? Yeah. Okay, so these studies, of course, all the studies are show superiority in terms of the disease progression, survival, and all those things. All the drug I mentioned to earlier. And this is the most so-called now promising drug. It's called olatornib. You can see it gives a survival up to 70 to 60%. So this is the only drug which is, I told you, expensive, 88,000 per month. Of course, it doesn't come with anything. It comes with all the side effects. If you use the efficacy, olatornib is outright all the available drugs for ALK. So olatornib is more superior. And now we can start it as the first line. Last time it's only for second line. Now we can start as the first line treatments. Okay, to try save some money, maybe for your friends or anybody. All right. Okay, so what we do in the University of Malaya, there's the only option. We have all the university. We are much enrolled in all clinical trial. So now we have a 20 clinical trial ongoing. We try see which patient are suitable. Most important is suitable. Not everybody will be enrolled into the study. So most of our patients who are enrolled, these are the medications, those who are enrolled during the studies. So after the study finish, so the ethic always approve for them to get the medication lifelong free, if the ethic study approve as such. So as long as they don't disease progress, they don't have other issue, they can continue this drug. So I have a longest patient using this more than 4 years. So that's another advantage. If you're going into all the HKL do a lot of studies, I can do a lot of studies, especially in Putrajaya. HUKM also do a lot of studies. So if your family members, whoever have diagnosed lung cancer, always try to look in the websites or anywhere, try to embark into the studies. Because everything is free. Your CT scan is free, your follow-up is free. On the top of that, they give you money. Every visit, 100 ringgit or 150 ringgit, you got copy money lah. Alright? Okay, so the conclusion is, so lung screening should come together with the smoking cessations. And we know it should not come only lung screening without a smoking cessation. This become a big, huge hurdle for us. You can see kids start smoking at the age of 12 years old, 13 years old, even younger than that. And of course, it will reduce long-term cost if you're able to detect the lung cancer earlier stage. You can see all the drugs, also you can, all the drug, not your finish. All the drug, it can be reduced the cost. When the lung cancer, we also have a trial shows, during the screening, we also can detect other diseases like a COPD, any heart problem and all those things, okay? So as I mentioned earlier, the study actually shows the positive study in terms of lung screening to be employed. So we should advocate lung screening to those who are high risk criteria, okay? Yeah, thank you. So, okay. Any questions?
Any questions, guys? Any questions?
Any chance that targeted go into generic?
Oh yeah, we have, I'll give you a story. So when I was joined University of Malaya 2014, I was the internal medicine physicians. I already using first generation TKI. TKI is a thyroid kinase inhibitor used for adenocarcinoma. So when I go back to Selayang for a short period, because we need to go for gazettement, nobody knows what is the gefetinib. Because that time gefetinib cost 3,500 when I start using it. Because of generic, now KKM already buy this drug and it's only cost 400 ringgit per month. So there are some drug already available in the generic for targeted therapy, not all, because the innovator still hold the patent right. So because of that, we cannot bring a lot of generic drugs. The patency is still valid. So some drug already have generic drug. For ALK, none.
The effectiveness of the generic is as good as
Good. Don't worry, our NPRA is very good on that to make sure we have a good quality of a generic drug. Equally good. So now the price come down to 400 plus. So we have a 2 generic drugs. The patient buy 450 ringgit per month, which is affordable to everybody. Now KKM use a lot. Means we already have experience more than 10 years. Now only all the ministry hospitals start using it. So now this is for the adeno-CA EGFR positive. For ALK, no generic yet because it's still fresh from the oven. So the innovator might not give up the patency right.
Actually, doctor, I have a question. What would be the difference between a generic and a brand name drug?
Okay.
The price difference is like 7 times.
Okay. So the generics, actually, what they do is, how the generic comes. Okay. So why the innovators sell the drug expensive? Because they invest in the research. So they innovate the drug. So they do what they call phase 1, phase 2, phase 2 trial. Just to give you an example, in order to a drug to be sold, a drug company need to invest nearly 2 billion USD. Any of the chemo drug, especially the tablets. So when the patency, that's why any part of the world, Malaysia part of the world, that they give a rights to this innovator brand to hold the patency for certain years, so that they can sell the drug. There's no competitor and everything. So what the generic do? They do something called biosimilar or bioequivalent studies. So they will take this drug and they do their own R&D research, okay, and they will actually extract the molecule, all right, one by one, and they do a biosimilar or bioequivalent studies. So they must show a bioequivalent, a biosimilar study so that this drug are equivalent to the innovator. So why the price is cheaper in innovator? Because they don't have other costs, all right, and of course the APIs become cheaper, yeah, because of that.
Sorry, Doc, I missed what you mentioned just now. What's the name of the drug you mentioned? The drug from 2,400 generic?
Or Gefitinib. Gefitinib.
How do you spell that?
Gefinitib. Gefitinib. G for Ghana. Yeah. So that was old drug. Now we no more using it already. So we have another latest one, third generation, called osimertinib. But osimertinib is still high. That drug was initially, when I started using 2017, 1 month it's 27,000. So you buy 1 month, you get 2 months free. So approximately 10,000 ringgit. So because of the efficacy, the indication are many, so the price actually come down now per month 6,000. So eventually the price will come down, depend on the indication, depend on the number of the patients you're using, depend on volume.
For the generic drug research, do they have any law that, like for example, there's a drug going to expire in 2026, so generic drug can come out after 2026, but do they have any law that limit they only can start to have this kind of research on generic drug after 2026, or they can start to have it now and then wait for the time of 2026 and release it?
Yeah, okay. So all the generic companies, okay, they will look at the market value, all right? I'm not talking about pharma economy here, just give you an idea. So if example, a drug already have a patency right, okay, and it's been there for market for 10 years, they know this patency globally going to be expired in 2-3 years. So the company evaluate whether it's good to invest in this drug. They do their generic studies. Of course, they cannot sell until the patency is expired. If we sell before the patency expired, the generic drug can sue you. This is the agreement already signed from most of the countries. So if given a little bit of exceptions, for instance, for the India, Bangladesh and Pakistan, That's why in Pakistan and Indonesia, they don't participate all the international trials. If you break these rules, it means you don't care for the innovator drug, the trial might not come to Malaysia. So you don't have experience using this kind of trial. Why trial important into Malaysia? Because it brings revenue. So you bring more than $1 billion revenue to Malaysia so far. If you do CRM is our clinical research of Malaysia, it's bring a huge amount of revenue to Malaysia. So that's why we are hold very tightly on this patency right. So of course the body who govern this, our pharmaceutical division at Petaling Jaya. So we hold this very, very strongly so that we have access to the patent drug, and the drug company willing come to Malaysia actually to give out this drug to all our patients. Maybe as you said, maybe the what you call the innovator will take maybe another 2 years to be sold globally, but many of our patients already benefited, as I mentioned, lorlatinib, right? So we already started lorlatinib many years ago. So many patients are benefited. More than our center got more than 15 patients who are benefiting. So this is another access we look at in a positive way. Of course, if you look in cost-wise, it's difficult to argue. Yeah.
Sorry, I don't come from medical background. Can you explain the difference the first generation, second generation, third
Oh,
generation?
okay.
And what happens when the third generation lorlatinib doesn't work anymore?
Okay. So the first generation is a bit older version. Second is a bit newer version, and third generation is newer version. So the indication is differ. If you talk about ALK, why lorlatinib is much superior? Because it do cover for brain metastasis. Like first generation crizotinib will not effective for brain metastasis. That's number one. Number two, overall efficacy is much superior, mostly in the third generation, especially lorlatinib. You can see the curve is much wider, isn't it? So the people who are actually benefiting, responding, and surviving, we call overall surviving, is much higher in the third generation because it do cover more broader genetics. So it inhibit the cell division in the tumor cells.
Lorlatinib is the most effective one.
We can say so, but it also depends on the indications and everything. So usually we start those patients already showing some brain metastasis, we can start. Or the patient is affordable, yes, we can start. It's like you go and buy a car. I only have 40,000 in my car. Of course, you cannot buy a BMW lah. You have to buy the things. Of course, it's not so bad. You still can drive car. If you cannot, if you already afford, of course, you can move for a better car. Something like that.
No side effect taking it long term, lorlatinib.
Okay, I already mentioned the side effect. So most common side effect, your cholesterol shoot up. And you can get the high BP. That's why we monitor many patients. We already starting the patient with the cholesterol medication. We monitor